Okay, let's talk about distal radius fractures. The rehab is going to look really similar to a scaphoid fracture because, as I said in the scaphoid fracture PPT recording, these are just considered wrist fractures. So they're very, very similar. There's just a couple of things you need to think about with a distal radius fracture that's slightly different than a scaphoid fracture. And I would say that the population of people that end up with a distal radius fracture is also slightly different. So those are just the little gems that are important to get from this lecture. So just as a reminder of what that anatomy looks like. So the distal radius is the big bone, right, at the wrist, with the ulna being the smaller bone. And it's important to sort of recognize that with this kind of fracture, you can get what's called radial shortening, which means that with that injury, the radius kind of moves more proximally, so kind of further away from the carpals, which can definitely cause pain and irritability and all of those things. So, and then it also causes the radius and the ulna to not line up anymore distally. And so that can also cause some irritability. So just, again, anatomy, just kind of consider what that looks like and how that might affect rehab and kind of quality of life. So we have to think about multiple joints when the distal radius is happening. So the radius and how it articulates with the carpal bone. So we talked a lot about the scaphoid and also the lunate. And then also we have to think about the ulna and how the ulna is articulating with the carpal bones. And then we also have to think about the radius and the ulna articulating to each other. So radius and ulna distally definitely affects supination and pronation. So we definitely have to consider those things as well. Most of the load when we were to put our hand, let's say, on the chair to push ourselves up to standing, most of the load that we would push through is the radius. So 80% of loading is the radius. And so we have to kind of recognize that, obviously that's going to be affected with a fracture to the radius. And that's also where we're going to get injuries when we have an injury. So again, most likely common way we get injured is hyperextension with that fall on an outstretched hand. And so you're putting your hand down, the compression is going through the radius, and it's usually with the wrist in significant extension or hyperextension. So that's where you're going to end up with that fracture. What's called the metaphyseal region, which is the picture is showing that region on the radius. This metaphyseal region has 30 to 50% less cortical bone. So it's more likely to have a fracture. So it doesn't have that really stable bone. And the diaphysis is going to be kind of distal to that. So you're just more likely to have irritability and I'm sorry, not irritability, but fracture in that area. So it's a huge number of fractures. Distal radius fractures happen a lot. So in the ER, it's anywhere from 18 to 44% of all fractures are distal radius fractures. And it's definitely most common in females of an older age. So over 50, this says, over 60, over 70. So again, these are older women who, when they fell, they didn't fracture the shoulder, which is probably a good thing. They didn't fracture at the elbow. Instead, they fractured at the wrist, and specifically the distal radius, not the scaphoid. So what puts us at risk for these fractures? Decreased bone mineral density, which is common when we get older, and that increased fall risk. So how's their balance? How's their overall mobility? These are things we definitely have to think about because that's probably what led to the fall to begin with. We're going to diagnose this with radiographs, MRI, CT scan. They're going to show this pretty easily. It's not like a scaphoid fracture where you may need to do more imaging. You may definitely need something like an MRI. Most of the time, an X-ray is going to show a fracture relatively obviously. So non-operative treatment looks like operative, like post-operative treatment really. There was a nice little study in 2016 out of Fuzhou that basically said that non-operative management shows similar results to actually doing an ORIF, so a fixation, as long as the fracture is non-displaced. So if the fracture is all lined up, there's no need to put in the hardware. And so instead, you're going to cast them and probably cast them or immobilize them for the same amount of time that you might with a operative fracture. We'll talk about the timeline for an operative fracture here in just a little bit, but you are going to cast them for a period of time, and then results in terms of outcomes are going to be very, very similar as it would be if you put in the hardware. So again, treatment progression for non-operative treatment is going to look very similar to to post-operative treatment. And we'll go through that in just a second. So they're going to choose to do surgery. And most of the time that's going to happen because the fracture was not adequately reduced. So again, it's not in the best position. And so you can see in that picture on the right, on the far right, that's a situation where you're not going to get union. You're not going to get a good alignment unless you do surgery. So displacement parameters, basically they're going to say if there's a certain amount of angulation. So this says less than 15 degrees of dorsal angulation, but that actually means like greater than, right? So if they're measuring greater than, then they're going to do surgery. And then also if there's that radial shortening, so the radius went proximally, it moved proximally, so they need to bring it back down and reposition it. Those would be reasons that they would do surgery. There's more of a risk of having displacement. So again, that picture kind of showing how it doesn't line up if they're older and they're female. So, and I don't know that we have a really great, I don't know that anybody's figured out why, but I kind of have my theory. I think it's that women tend to use their hands more expressively and move their wrists more than we realize, because we tend to talk with our hands more. We tend to move through that area of our body more. So I think it's one of those situations where there's probably other things like osteoporosis or other related complications that probably lead to secondary displacement. But I think it's also just the fact that we're very active with our hands and our wrists in this case, so it might lead to secondary displacement. So again, as I kind of mentioned with the last slide, outcomes at 1 year, they're not significantly different with conservative versus surgical treatment, but they did find, some of the research in the last 8 or 10 years did find that you do possibly have better grip strength if they do surgery and they do some sort of internal fixation. So there is that possibility that maybe you get a little bit better outcomes if they're doing the surgery. So surgery is usually open reduction and internal fixation. So ORIF, we've heard that before. They're going to use these plates in there to lock everything in and keep it stable. These surgeries, like I said, with every other fracture surgery, most of the time they're not terribly complicated. It's just a matter of getting that distal radius lined up and then securing it all together. And I'm sure a surgeon would say that it is complicated and that what they do is very important. And I'm definitely not disregarding the surgeon. I'm just saying that it's not like a crazy, amazingly interesting surgery for those of us who don't do surgery. Unfortunately, malunion is a pretty common complication. This says up to 60% of the time they could have a malunion. And malunion, when it occurs, can definitely lead to decreased grip strength. So that means decreased function. Obviously, gripping is extremely important. And so if we're not able to lift things with both hands or just lift things with that involved side, eventually that can be a big problem. This also could lead to, and you can see in the picture, it's kind of a difficult picture to look at, that the carpals aren't aligned anymore. And so again, if this is a bad enough injury, and during healing, somehow we're not in alignment, and those carpals you'll see are shifted radially in this case. That can also lead to decreased grip strength, decreased range of motion, lots of complications. So that alignment during the initial phase, especially after fracture, is really important. So we'll talk about that a little bit more. Other complications, there could be some tendon and nerve related issues if it's malaligned. So those of you who kind of remember your anatomy, the median nerve is going to travel through the carpal tunnel, right? But then the ulnar nerve travels around Goyan's tunnel on the ulnar aspect of the anterior part of the hand. It goes right by the hook of the hamate and the pisiform bone. And so you could see, like even in this picture, with that shift, that ulnar nerve now is probably not lined up correctly. So that could prove to be a big problem with sensation or other, innervation and any of those issues. However, if the patients basically can get good grip strength, then, even if they don't look pretty, even if there is a malalignment or a malunion, then you're fine. And we've definitely seen lots of patients that even though it doesn't look really pretty, we're able to get good grip strength. There isn't any nerve damage, and so we're fine. And that definitely can happen as well. When we talked about scaphoid fractures, we talked about this complex regional pain syndrome. This can certainly happen with the distal radius fracture. And so it's really important, again, that we are trying to improve mobility early, trying to decrease immobilization for too long, and then watching for weird sensory issues. So complex regional pain syndrome, you guys sometimes will call shoulder hand syndrome. And it basically is this weird hyperactivity of nerves that it mostly affects the lower arm, so the wrist and hand. Sometimes it affects further up, more proximally. But it's this change in sensation, usually change in color, change in temperature, sometimes sweating in the hand after a trauma. So we have to really kind of watch for this after these fractures. So if we're seeing them preoperatively, we want to decrease swelling as much as we can, so using elevation and a little bit of compression. We also want to make sure that we're working the shoulder and scapular muscles. So we've talked about this a lot before, and we talked about it with the scaphoid fracture. So if you remember, we looked at that interesting research that said that people were having more shoulder issues after a scaphoid fracture, which is such a weird thing. But again, I just think that people aren't using that extremity at all. And so they end up with rotator cuff problems and things like that. So make sure that the patient knows, again, either immediately before the surgery or immediately after the surgery, that we're giving them some things to do for their shoulder and their elbow, so that we don't end up with any complications there. And casting or splinting, there's a lot of variation when it comes to how long they wear a cast or a splint. So it depends. I think, it depends on the surgeon. In China, everybody, as we've talked about many times, is very conservative. So you could end up casted for a long period of time. I don't know. We're crossing our fingers that maybe they're in something that's relatively temporary and we can get them moving. Because there was really good research. Well, I mean, it's only 15 patients, so not a huge study, but still good research from 2016 about doing early mobility. So basically, this is 15 patients who had a distal radius fracture. They were given a removable brace for 1 week. They were allowed to actually do active range of motion right away. But it was monitored by a PT. So a PT was able to have them do active range of motion at the wrist and then do exercises for the shoulder, the elbow, and the hand. So like real exercises, resisted stuff and stuff like that. But again, active range of motion at the wrist immediately after ORIF. So they had fixation. Okay, they were allowed to move. After 1 week, they were encouraged not to wear the splint. Okay, and actually to start doing light ADL. So start doing a little bit with lifting or carrying with that involved side. These patients also kept doing PT until their range of motion was within normal limits, however long that took. And then 13 patients were the kind of control group. So they were immobilized in a cast for 5 weeks and then performed PT until their range of motion was within normal limits. Okay, so we had one immobilized for 5 weeks, one that was allowed some movement right away. Early mobilization group basically did physical therapy for about 2.7 months total. Late mobilization group did PT for 4.2 months. So not twice as long, but well over a month longer than the early mobilization group, which again, we want to get them out and back to their lives fast, right? That's our goal. So some other outcomes from that study you'll see here. This is range of motion, flexion extension. Okay, so they started measuring at 6 weeks. The early mobilization group is the blue color, and the immobilization group that was immobilized for 5 weeks is the green color. So you can see significant improvements in range of motion all the way up to a year. Their flexion extension range of motion, they were getting up to 120 degrees at a year, and they got there relatively quickly. I mean, they were moving up very quickly. Pronation, supination, a little bit more similar, the early mobilization versus the immobilization groups. And at 1 year, they were pretty close to the same, but still better and improved more quickly in the early mobilization group. And then the last thing that I think is, again, probably the most significant is our grip strength. So grip strength, they're measuring in kilograms. So they're starting off at 6 weeks at totally different places, right? So grip strength was less than 5 kilograms for the immobilization group, but it was 15 kilograms for the mobility group. And then after 1 year, the grip strength was significantly improved. 27 kilograms versus 23, 24. So yeah, there was a big difference all the way through as they followed them. So this is the patient. This is one of the patient's examples. This is 6 weeks after surgery. 6 weeks. This was a group that did the mobilization, early mobilization. You can see her hardware here. It's a good amount of hardware. And this is 6 weeks later. Her range of motion is almost totally full range of motion. 6 weeks. So this type of protocol does exist. If your doctor's up for letting you do it and you feel confident and ready to do mobilization earlier, I would say have the conversation and consider it, because you can see that these outcomes are really good. But let's go back. Let's say, okay, let's look at the standard. What's the standard for immobilization and therapy? So the first phase is actually only a couple weeks, okay? The first phase is you want to protect that surgical site, but you actually do want to start moving. You also really want to make sure shoulders and elbows are moving. During the first phase, scar management, so scar mobility is good. 1 to 2 weeks of immobilization is fine, okay? Fine. You guys are going to see that. It's pretty common. But only 1 to 2 weeks, okay? If you do, what they have found is that within 10 days, there will be changes in connective tissue. So you really, again, you don't want them immobilized for too long because it's going to affect their outcomes. It's going to affect how quickly they can get back to function. What they've also found is that early movement, does not increase the risk of secondary fracture displacement. So again, encouraging movement, talking with the doctors. You guys have to talk to your surgeons about this. But then if the surgeons are okay, making sure that the patient understands that movement is okay. So fear with this patient population is the biggest problem by far. These are older people. They had a fall, so that was traumatic. They now have been told they have this fracture. These fractures can be somewhat painful, and the doctor says, okay, let's put you in a cast. But in that cast, we still need to move your fingers, and in that cast, we still need to recognize that once you get out of the cast, the movement is okay, and don't be scared, because that's where we're going to end up with patients overprotecting and then having complications. So treatment during those first 2 weeks is a lot of active range of motion, shoulder and elbow. You can certainly do finger and thumb motion. Active and active assistive finger and thumb motion is totally fine. Tendon glides, making sure the tendons, extensor tendons especially, are moving. And then doing elevation for swelling. And then play with like fall activities. So if this was from a fall, if their balance isn't good, you could certainly do a Berg balance test and get a baseline for their balance and start working on balance activities during the first couple of weeks. Nothing wrong with that. And so by week 3 to 5, we're really, really hoping that our primary focus is decreasing fear of movement. So they may or may not be using some sort of splint after 2 weeks, but they really shouldn't be using a cast. After 2 weeks, they really should be out of a cast. Our goals are to get to range of motion actively 75% of the uninvolved side. So this is quick, right, you guys? I mean, this is a month after a fracture, right? 3 to 5 weeks. That's a month after a fracture. We should get active range of motion 75% on the uninvolved side. We saw those pictures of that girl 6 weeks after, and she had almost full range of motion. So it's possible. It's doable. The other goal is we're checking sensation, making sure that there aren't any sensation issues. So patient education, you are going to keep having pain if you don't move. So if you overprotect, you're going to have more pain, and the wrist is not going to heal correctly. So you need to make sure they know that movement is good. Movement is good. Movement is good. It will help with all the complications. Okay. Sometimes, again, the doctor will say continue to wear some sort of splint. Sometimes they won't, but it should be a splint that they can remove, a removable splint, so that you can do active range of motion and passive range of motion during this phase. You also can lift up to 1 kilogram, which is kind of a lot by the end of this phase. They can be using that hand for some lifting. So what does our treatment look like? Active and passive range of motion of the fingers and thumb. Active range of motion of the elbow and shoulder. And this says passive range of motion of the fingers and thumb. Sorry about that. That should be active and passive range of motion of the wrist. That should be the first one. Sorry. Active and passive range of motion of the wrist. Active range of motion, elbow and shoulder, and then passive range of motion of the fingers and thumb. So the wrist can move, okay? That's what I need to get out of this. I'm sorry I'm sorry I didn't fix that slide. I feel like that slide was changed or something. Interesting. If they have sensory issues, your other big part of treatment is desensitization. So if you don't know anything about that, desensitization, you can basically do different things. The picture is showing a towel You're starting with, if they're really sensitive, the hand is sensitive, which definitely happens. It is a complication from the surgery where there can be a significant sensitivity of the hand. If that's true, you are going to use something that is soft, where it feels a little bit hypersensitive, but it's tolerable. They can tolerate it. And they're literally just going to rub that on their hand for 3 minutes. They're going to rub it all over wherever there's sensation issues, hypersensitivity. And they're just going to rub it through the fingers, through the thumb. And then once that becomes very comfortable and there's really no sensation issues with the towel, then they're going to go to something a little bit rougher. So maybe a rougher towel, or just another type of object, getting to the point where they can use something like, we would say, sandpaper, Velcro, that the Velcro that we have on shoes and different things. That kind of thing is very rough. So they're working their way up to that for desensitization of the hand. There are other techniques for desensitization as well, but that's certainly one that we can consider using. These guys would also probably benefit from mirror therapy. So we talked about that with the scaphoid. Mirror therapy can also be helpful if there are sensation issues. So you can actually do active range of motion with these patients during this phase. So you could have them look at their good side, put their other side behind the mirror, and then do your active range of motion of the hand, the thumb, the fingers, the wrist, all of those things. So by week 6, we're definitely getting back into normal life. So this is fast, and that's the problem, is if you're not getting them until week 6, then they've probably had complications, and they're probably very stiff, and they're probably very fearful. So that's what makes this hard. But hopefully we're getting them earlier than that so we can get them moving, and then they have much better outcomes. So we really do want to be doing normal ADLs by month 2, 3, 4. They should be back to using that hand with everything that would be their normal activities. So I think it's important that they recognize that pain is normal, and that they may have some pain for up to 6 or 7 months after the injury, but that shouldn't stop them from movement, okay? That they should be able to see changes in function, and you might need to point that out to them. So I think sometimes you have to say, okay, I know you have pain, but look, you just use that hand to, unbutton your jacket, or zip up your jacket, or you just use that hand to grab the water bottle. So even though there was some pain, you obviously, you can improve your function with the pain, and the pain will go away eventually. So don't let that stop you. Another big thing that I know in China, everybody wants to have the hardware removed. What the research has found, however, is that with this particular fracture, this distal radius fracture, removing the hardware could actually end up causing more problems, especially if they're high irritability, especially if there's nerve involved. They really would suggest, surgeons would really suggest keeping the hardware in. So if the patient's saying, well, I have all this pain, but once the doctor said I could take out the hardware and everything will be better, that's oftentimes not the case with this particular fracture. So make sure that they understand that and say, try to say, hey, let's just keep working on this. Let's try to keep working on that range of motion and things. And maybe, at 7 to 10 months after surgery, maybe if the sensitivity hasn't changed and your range of motion hasn't changed, then, you could reconsider removing the hardware, but it's just not recommended. So our treatment is going to be, you can start actually doing passive stretching of the wrist at this point. So remember, we've talked about how active range of motion and even passive range of motion is a lot less intense. It's definitely going to cause less irritability than passive stretching. So in this case, passive stretching, we're waiting until phase 3 because it can cause more irritability. So you can see pictures there, kind of that weight-bearing extension stretch, which we definitely want to do, can be helpful at this stage, kind of weight-bearing, kind of pushing through the hands to stand up. Those kinds of movements are going to be very appropriate during the third stage. You're also going to be spending a lot of time working on grip and doing grip with different wrist positions. So again, when we talk about women, especially, we like to have our wrists in funky positions. It's not common for us to have a really great neutral wrist when we're doing things like lifting or gripping. And unfortunately, if our wrist is in a lot of extension or deviation of some kind, then we end up with more pain and sometimes more injury. And so teaching patients how to stay in a neutral wrist position while they're gripping, and then taking them out of that neutral position, putting them in a little bit more extension, putting them in maybe some radial or ulnar deviation, and working on that is going to be really important. Obviously, strengthening, we're getting in that third phase like we always do, and then the weight bearing, which I said, like putting the hands down, either, you can put them on the wall for a wall push-up or put them on a table, something like that, to not only work on kind of passive extension stretching, but also weight bearing, which can help with bone healing, make it strong, and then also just keep the mobility going. So last phase 4, starting at about 4 months. So again, this group is usually older. You might be getting them back to something like badminton for sure, table tennis, maybe tennis. That's possible. So what a lot of the time, again, with these older people, you need to tell them is the pain should start going away. If you still have pain at 6 months, it should start going away at 6 to 7 months. But it might take up to a year to get full grip strength. And so again, if you remember those pictures I showed you of that study where they did mobilization early, at 1 year, you saw that they were still improving on their range of motion and their grip strength during 1 full year. So if they're discouraged at this point at 4 months, when you're probably discharging them, that they don't have full strength, you can explain to them, hey, that's still going to get, you still got however many months, in this case 8 months or whatever, to kind of get grip strength back, and it's normal for it to take that long. So again, big take-home message with distal radius fracture: try to convince doctors and patients to move early and decrease fear, and really watch for any type of sensory issues with this group.